Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. This episode features content from an educational video titled Emerging Insights on Outpatient Management of Acute COVID-19 and Long COVID in Europe. During this podcast, Dr. Jens Lundgren, professor at Rigshospital at the University of Copenhagen, and Dr. Barbara Rath, co-founder and chair of the Vaccine Safety Initiative in Berlin and the United States, discuss outpatient management of acute and long COVID in Europe. For more information about Dr. Lundgren and Dr. Rath, and for a link to the full online educational program, including downloadable slides, please visit the links in the show notes for this episode. Now, let's get started and hear what Dr. Lundgren and Dr. Rath have to say about acute and long COVID in Europe.
Welcome, folks, to the CCO program. Today, we have a really interesting topic, pandemic perspectives, something we've all learned the hard way over the recent years. And the focus today will be emerging insights on outpatient management of acute COVID-19 and long COVID in Europe. The faculty today will be Dr. Jens Lundgren. He's professor at Rigshospital at the University of Copenhagen and director of the Center for Excellence for Health, Immunity and Infection, CHIP, at the Rigshospital at the University of Copenhagen in Denmark. And myself, I'm the co-founder and chair of the Vaccine Safety Initiative, which is based in Berlin, Germany, and the US. I'm research director at the University of Bourgogne-Franche-Comté in France. And I'm also involved with ESCMID, which is the respiratory virus study group for ESCMID, and the board at ICERV as the chair of the ICERV epidemiology group. This is the International Society for Influenza and Other Respiratory Viruses.
So let's turn to the first section of the program, the current COVID-19 landscape. As we know, Omicron took over from Delta in the late part of 2021 as BA1, as it was called, rapidly transitioning to BA2. But subsequent to that, this virus has really evolved. And there is a multiple subvariants, including what was dominating over the summer, the BA5, but now also additional follow-up variants on top of that. This mostly is reflected in how the virus is changing in the spike protein, which have implications for some of the treatments that we're using, in particular the monoclonal antibodies, and we'll come back to those issues. But this is really now a soup of sublineages of Omicron. And these new variants is starting to emerge around the world. This is a recent publication that gives you a sense that in different countries around the world, there's now a mixture of the original BA5 that dominated over the summer, but also these new variants, XBB, BQ1, and so forth. So now let's focus on the antiviral drugs, so the small molecules that inhibits replication. We have essentially three drugs to talk about here, which aims in the outpatient setting to reducing patients' risk of hospitalization and death. Typically, you want to give those agents within as soon as possible after symptom onset, because that's where you have the opportunity to then soften the course of the infection and therefore reduce the risk of hospitalization and death. It is therefore critical in populations where these treatments should be considered to have a very effective test and treat concept rolled out that includes also primary care, as typically, obviously, patients in this situation have not yet been hospitalized. There are three drugs we will talk about: molnupiravir, nirmatrelvir, and remdesivir, and where the latter two drugs have been shown in trials, in randomized trials, to reduce the risk of hospitalization and death up in the 80s, whereas this was not the case for molnupiravir. There is a number of observational studies subsequent to those randomized studies that have shared further insight into how effective these drugs are. This is a study from Hong Kong where it was a retrospective analysis and where they are assessing over 40,000 people, of which 2,500 was receiving molnupiravir and around 1,100 patients with the nirmatrelvir, which obviously is combined with ritonavir. there was in this cohort a low rate of full vaccination, and I think that's important. So in the propensity matching with controls, the investigators found around 40% reduction in the risk of progression if patients were using these drugs as opposed to not using them. And there was also a signal for mortality, slightly better for the latter drug compared to molnupiravir. And obviously, as you would expect, also a shorter time until you had the low viral load in your nasal cavity. Importantly, in subgroup analysis and sensitivity analysis, this benefit was not seen in people younger than 65 and in fully vaccinated patients. So really the treatment benefit in this study was pretty exclusively in the older part of the population. In a study from Israel during the Omicron surge, again, a retrospective study of people older than 40 years from the early part of this year, over 100,000 patients enrolled, around 4,000 of those that were treated with nirmatrelvir, of which 2,500 was older than 65. Again, also here, there is really reproducing the findings from the randomized trials, a striking benefit, again, also similar to the other trial, which was mostly seen in patients older than 65, where, as you can see on the top left, if you were not treated, the risk of progression to hospitalization was around 15-16%, which was dramatically reduced among those who were receiving the antiviral, whereas the risk of progression in younger people were obviously much less, where you cannot see a discernible benefit. One issue you need to be aware of when you're using those antiviral drugs is the risk of COVID-19 rebound. There's a number of studies, most of them not yet published in peer-reviewed journals. This is the preprint. Really important to emphasize that rebound can either be a biological rebound, so people have cleared their virus while they were receiving the drug, but subsequent to that, again, become test positive, or it could be a further progression of the disease as you stop the antiviral. This has been seen for both molnupiravir and as well as for nirmatrelvir. The rates here is around in the below 10%, so it's not something you would expect to see in most patients. And likely this is explained by the fact that at least in some patients, the underlying infection and replication of the virus has not been fully controlled by the immune system at the time when you're stopping the medication, which is given for 5 days. And as a consequence, since the treatment is not eradicative, you would expect to see some degree of rebound. Now, the issue with monoclonal antibodies, obviously the first antiviral drug class that we were using in the pandemic, because of the Omicron have evolved itself in the spike protein where these monoclonal antibodies bind to. Importantly, in particular for these more recent subvariants that has emerged in the last month, since October of 2022, Evusheld have lost activity against several of them, BQ1, BQ1.1, and XBB. Tilnovimab have retained some activity against some of them, but also is struggling to have activity against XBB and the same type of variants, in particular XBB and BQ1.1. And therefore, it is a really clinical dilemma at the moment whether one should continue to use those monoclonals, as the use of them really requires you to understand the current contemporary type of subtypes that is circulating in your population. Equally, for people who have received these drugs earlier, they may, if they're exposed to these new variants, may not still experience a prophylactic benefit due to the fact that these new variants have emerged. So ESCMID have providing COVID-19 guidelines, really 4 sets of guidelines focusing on diagnosis, drug treatment, and clinical management, post-discharge and long-term follow-up, as well as guidelines around prevention and efficacy of individual protective measures, really employing a framework of adoption, adaptation, and development, and therefore really worthwhile to study. Graphically, these guidelines look like this for patients with mild to moderate disease. Patients with mild or moderate COVID-19 with symptom duration less or equal to 5 days and risk factors for clinical progression. And remember here, risk factors for clinical progression, older people, people with significant comorbidity, underlying organ comorbidity, as well as people who are suffering from immune perturbations. If people are fulfilling those requirements, you need to consider whether they're fully vaccinated. If not, the strongly recommended intervention then to give to those patients will be Trilvir in combination with ritonavir or remdesivir. If they are fully vaccinated but have not responded, so you know that they have undetectable receptor-binding domain anti-SARS-CoV-2 antibodies, if you know that's the case, they will still get the same treatment. If they are indeed detectable or you don't know, you will need to then assess the risk factors for vaccine response failure, and then you can stratify the patients, as you can see, into either the yellow box or the red box, which are the most uncertain for those which have no risk factors for vaccine response failure. The point of this slide is really to bring out the potential barriers for outpatient management. You want to consider, if you have patients where you consider nirmatrelvir and ritonavir, there's the potential for drug-drug interactions, in particular for that drug, and therefore may not be used in all patients. The second issue you are faced with is whether you have the possibility of providing intravenous treatment or whether you can only give people tablets. Obviously, remdesivir is infused intravenously, as is monoclonal antibodies. For patients who have symptom duration for 6 or 7 days ago, at least the evidence is providing only relatively few options here, in particular remdesivir, and we have talked about monoclonal antibodies as a potential other option. So in summary, we have 3 small antiviral agents. For the first 2, we really want to try to get them initiated within 5 days of symptom onset in people with risk factors. The pill burden is reasonable, although you want to make sure that people continue to take the medication for the full duration of the 5 days. The side effects vary slightly depending on which of the agents that you have, but in most situations are well tolerated. There's clearly issues of using the drugs in pregnancy, as there is not really a comprehensive assessment of potential teratogenic effect, and that may be, therefore, a situation where you would be more cautious and more conservative not use them. In people who have renal dysfunction, you can use molnupiravir, but in people with low EGFR, none of the others are recommended. And equally, if you have people with liver dysfunction, near the Trilvir, which is obviously excreted via the liver, you should not use that drug in people with Child-Pugh C. So that was a brief overview of the current landscape. Obviously, what is changing here is that we have small antivirals. On the other hand, that we have the virus has been evolving, and the role of monoclonal antibodies is becoming smaller and smaller. So maybe just to come to my co-faculty, what is your sense of what are we learning here in terms of making sure that we use those treatments here for outpatients? Barbara?
I think one of the problems is the complexity of these guidelines and how to communicate those to a lay person. I think for compliance with whatever medication, it has to be considered that the benefits that are to be expected and the use and the side effects and all those things be communicated very consistently, which is part of why we're providing this training to make you as a healthcare professional more confident in your consultation. In modern rapid clinical practice, these things sometimes fall through the cracks, which may lead to people saying thank you very much, but not complying with the medication, which might result in incomplete treatment courses, increasing risks of drug resistance, rebound, and a number of other things we do not want to see. So I would say it's really important to put these guidelines in simple words as far as they apply to your patient, and reiterate the importance of completing your treatment cycle and letting you know directly and without much delay if there's anything that you think is a new question that may have arisen during treatment, so that you keep that communication feedback loop going with your patient. I think that's my number one concern. That has, is manageable, but I think it needs good training and good clinical practice to get that going. The second question, of course, is children. And when will they benefit and to which degree? And always to think about children and elderly people are, when we approach treatment guidelines, they're always kind of the extremes of age are always a challenging population group because it's a moving target in which age groups drug will be licensed going forward. Some never will be licensed in children. Some take some time. But that's another topic for researchers to think about.
Yeah, just to make it clear that the guidelines, there is really not an approved antiviral for children.
As usual.
But just to make sure that people appreciate that.
Yes, and as a pediatrician, that's kind of our frustration, right? It takes a while until a drug is approved for children, until we look at specific risk groups. Also, pregnant mothers, as we had discussed, are still a group that is being studied. It doesn't mean the drug is per se a problem, but it needs to be studied and validated because children too have a right to have their studies done in their population group before something is licensed. So that's, something to keep in mind.
No, absolutely. I agree with all the points you made, Barbara. I guess one thing I really also want to stress here as a discussion point is the challenge to actually get people diagnosed and funneled into the treatment system in this early part of the infection. I have to say that part of the message here that I would like to convey is it's really important that this discussion is brought out into the public domain because typically people will not be contacting by themselves if they're not aware of these treatment options. They won't contact the health system in this early part of their disease and therefore really is missing the opportunity that they could potentially receive. So I think that's something which I think we should try to encourage, that there's communication, active communication into the public about the treatment possibilities.
Yeah, I think that's in general a challenge when it comes to acute respiratory viral infections.
It is.
From the old days when we had no antiviral treatment options, neither for flu nor for coronaviruses, the tendency was to be a hero as long as you could, and then to see the doctor when things fall apart, and then maybe see if then you had a bacterial superinfection and needed an antibiotic. So the antiviral component wasn't on people's radar, and that changes the entire ballgame here. And the idea here is to get tested and to be seen as soon as possible so that you don't miss the critical time period where these antivirals have their most potent effect to your benefit.
And as you say, it's obviously the same thing with oseltamivir and influenza, right? That the treatment benefit is much, much more pronounced if you get the people on that drug very early on after symptom onset.
Both oseltamivir, baloxavir, all antivirals for respiratory virus infection, I think is important to remember that. Also as a clinician, to realize that also makes it more important to nail your diagnosis, to know what you're dealing with, so that you can treat it specifically with an antiviral that is designed to address this particular virus. That's very important.
Thank you, Barbara, and thank you for that discussion.
So I have the task today to talk to you a little bit about long COVID. This is a topic that's been all over the media. There are a lot of concepts of what long COVID might be in people's heads. And it's very important to remember we are working on case definitions. We're all trying to understand better what this disease entity might entail. What we do know is that about 1 in 8 adults with COVID are likely going to experience a long COVID or some form of long COVID. This is, almost 13%. So that's a significant number. It is more common in patients who had required hospitalization. So in hospitalized patients, it's somewhere between 1 in 3 for females and 1 in 5 for hospitalized males. That's a significant number. That said, the numbers of hospitalizations are going down a little bit, so we hope to benefit in that aspect from seeing a little bit less of a risk. If you're able to stay outside the hospital, it looks a little bit better. But you can see here also that it is twice as common in females compared to males. And that's another topic of study, what may be the reason for this. It is very, very challenging, as I mentioned earlier, to create a case definition for long COVID. WHO has proposed one that is quite complex. and is still, something that is being looked at by multiple groups as they study this disease more profoundly. Also, you can imagine how difficult it is to do studies like that, because by definition, you need to observe a patient cohort for a long time to really see the cases. And secondly, the symptoms overlap with sequelae of other viral infections and causes. And there you have to discern which one you're dealing with, not to group everything under long COVID that is bothering a person after some form of infection. So you have to be very accurate at the time of the acute infection in order to then understand better which form of a long disease you're looking at. So the causes and the pathophysiology of long COVID is still being sorted out at this point. A number of potential causes of long COVID are being discussed, which include direct neuroinvasion, some form of a dysregulated immune response, may be autoantibodies, autoinflammation. Some of those diseases and other forms of rheumatologic or autoimmune diseases are also more common in females, so that's part of the hypothesis here. There may also be a reactivation of other viruses that are lifelong. As you all know, herpes viruses, or all viruses of the herpes group, can persist in your body, can evade your immune system to a degree that they can stay with you for the rest of your life, and can be reactivated when you need it least. In other words, if your body is already fighting off some other infection, and that can, of course, create fatigue. Then, of course, the COVID virus itself might be lingering and continuing some low-level replication that is keeping your immune system busy. Or it can be some kind of endothelial injury or ongoing endothelial dysfunction. That's still something that is quite complex to make a link from there to fatigue, but it could potentially lead to hyperperfusion of certain parts of your body. And then there's the entire post-ICU syndrome. We have known for decades that patients who come out of the intensive care unit need a long time in rehabilitation clinics or at home to really come back to their normal self. And that may just be a big recovery period. But there's also direct injury to organ systems that is related to some symptoms long COVID patients may experience. For example, if you're permanently short of breath, there have been good radiological studies showing direct tissue injury to the lungs, and also some hypoperfusion, as I said, some things that you would see on a CNS scan, or some reductions in the gray matter that creates this kind of brain fog or difficulty concentrating. So all of this is a work in progress. Probably it's a multiplicity of causes and results of these, and they may not look the same in 2 or 3 patients over time. So be open-minded when you assess your patient. It's also important to recognize what you see and to give your patient credence. If they complain about these kinds of symptoms, listen attentively. There are a number of risk factors that we do know that may be related to long COVID and a COVID-19. After the COVID-19 diagnosis, type 2 diabetes seems to have a linkage to long COVID. There may be the circulating SARS-CoV-2 viremia, which is what I said earlier. It's kind of ongoing low-level replication that people may be able to pick up on a PCR, for example. Then, as I mentioned earlier, Epstein-Barr virus has been known also for young adults. That infection alone can make athletes and otherwise very fit people be very low energy and unable to perform athletically and otherwise for a while. So if a SARS-CoV-2 infection were to reactivate Epstein-Barr virus, which is in your body to stay there, then that could be an indirect effect causing some of those symptoms. And then, of course, there are certain autoantibodies that I mentioned earlier. In particular, type 1 interferons are being looked at, and those autoantibodies that we also know from systemic lupus erythematosus. So all work in progress, as you can see. Then we have the question of how do we prevent long COVID and can we manage this better? One question, of course, is COVID-19 vaccination and long COVID. So what is the role of vaccination in the prevention of long COVID? There has been a meta-analysis of 70 studies with multiple symptoms that were being looked at after acute SARS-CoV-2 infection, either before or after COVID-19 vaccination. And again, the definitions of long COVID in these studies that were being meta-analyzed were very diverse, so that makes it very difficult to draw simple conclusions. There's a low-level evidence, grade 3, for those of you who deal with grading evidence, because it's coming from case controls and cohort studies, not randomized clinical trials, show that if you have been vaccinated before you got infected with SARS-CoV-2, then your risk of developing long COVID is being reduced. I repeat that because it's really important. So if you have been vaccinated before your SARS-CoV-2 infection, then this reduces the risk of developing long COVID. And at that, 2 doses are more effective than 1 dose alone. The impact of vaccinating people who have already experienced or in the middle of experiencing long COVID is debatable. That's still being studied. Could you strengthen your immune system to help it fend off long ongoing replication, for example? Now let's hear from a patient.
Then I had my first vaccine. I had an AstraZeneca in March of 2021 and felt wretched for 36 hours. And then I woke up and it was like the miracle cure. Suddenly I felt full of energy and I went down to the seafront. I'd gone back to Brighton at that point and found I could walk for an hour. And friends who'd been taking me for these very gradual walks, the 5 minute, the 6 minute, the 7 minute, were astonished that suddenly I was out there happily walking and the post-exertional malaise didn't come. And I declared myself cured. And I would sit on lots of long COVID advocacy groups saying, I used to have long COVID, got the vaccine, I'm fine now. I still don't have any antibodies, but by the time I got my second vaccine a few months later, I had finally developed some antibodies.
And as I said earlier, it's very important to take patients seriously and to give them credence when they come to you with complaints like this patient here. Now, vaccination post-long COVID is a question, of course. And the other question that we all ask ourselves as physicians is, can early antiviral use do anything or contribute to preventing long COVID? So the anti-SARS-CoV-2 vaccination is still the most potent way of preventing long COVID. These are the strongest data we have. Researchers hypothesize that if you have antivirals very early or even in a preventive mode almost, then you might also have the ability to decrease the viral reservoir and therefore lowering the risk of disseminated disease, which then may result in long COVID. There has been the panoramic trial looking at molnupiravir, and they're still collecting data 2 and 6 months post-treatment at the moment. There's the Solidarity trial looking at remdesivir in hospitalized patients. They will soon be able to report their 1-year follow-up data. And then there's the question of the combination of, or the boostering of nirmatrelvir with ritonavir and how that would work in preventing long COVID. And there's still several ongoing studies at the moment, which will assess their 6 months post-treatment data very soon. Then we have the diffuse picture of myalgic encephalomyelitis or post-exertional malaise, which means you're trying to exert your body again, do something suggesting you're back to normal and your body doesn't want to follow along. Here we need management strategies. And of course, footnote, this will also have implications for medical insurance systems and other financial long-term sequelae of COVID. The link between this myalgic encephalomyelitis and COVID is unclear, although fatigue is a common symptom in long COVID. And then there are strategies for the management that are being adopted for the management of long COVID, including pacing. So really you ask yourself what's going on, you review the case and you brainstorm. So now let's hear from a patient again who's describing some of those post-exertional malaise states.
It was, I think probably the hardest bit was not being believed. And friends and well-wishers would say, well, aren't you better now? And you wanted to be, I wanted to be, but I wasn't. And I would try, for example, to go out, visit my mother who was very unwell, not with COVID. And after 15 minutes outside the house, I'd have to be driven home because I just couldn't function at all. So this all kind of went on for almost 11 months. Of course, over time, I would have good days, and I would have days when I could walk a little bit more than 5 or 10 minutes. Sometimes I'd get as far as 20 minutes, but I would get what I now know to be post-exertional malaise. So if I would go to the supermarket and shop for myself, which is something I desperately wanted to do, I would then be bedbound for 4 or 5 days afterwards.
So there are a number of treatments on investigation for long COVID, and you can see here an overview of some of those attempts. Some are still, sorting out which therapeutic target we're really looking at and which kind of pathological changes we're trying to address. And then we're basically trying the drugs that we think would address this aspect. But as I mentioned earlier, this can be a pattern and a complex combination of multiple types of tissue injury and or symptoms that may need also a number of drugs to work in concert to help these patients. So if you talk about something as vague as brain fog, how do you address that? And how do you follow these patients? Is there a biomarker that you can follow to see whether your treatment is actually successful? There are a number of laboratory abnormalities that you can look at. You can sort out contributing factors. There are also lifestyle changes that may be needed. And there's, of course, a question if you can't pay attention, if you can't focus, there are a number of drugs that are being used in other forms of attention deficit that you can try here as well. Then, of course, the issue with dysautonomia, there are some lifestyle changes again. Hydration and salt intake can be improved. People can wear compression stockings. There are meditation techniques. And then if that doesn't help, you can think about hydrocortisone and other medications. Difficult because those have to be tapered off when you're done treating. And the question is, when are you done? So this is still being sorted out. Fatigue, yes, you pace yourself when you do exercise. You don't start all of a sudden. Many of us are getting impatient when we're not feeling well, and then we overdo it, and that may backfire in these patients. So tell them to pace themselves, to have maybe some advice on how to slowly increase their exercise tolerance. In terms of mental health, antidepressants may help. This persistent ongoing SARS-CoV-2 infection, that could maybe be mitigated if you try another round of antiviral therapy. If you think about Jens' notes on rebound earlier, sometimes maybe your 5-course treatment may not be enough and you may need more or extended period treatment. People who have sleeping difficulties, they may need to do sleep hygiene even more than the rest of us. And sometimes sleep aids may help, but as you know, these are also not without side effects. Amitriptyline has been tried to help the paresthesia associated to that. And then there's the small fiber neuropathy. Here you want to address the laboratory abnormalities. Sometimes correcting those can already help. And paresthesias, again, have a number of medications that you can look at and try. Again, treatment trials are needed and a lot more evidence in this area. So Jens, what do you think? Are you happy with the way things have gone so far in terms of addressing long COVID, both in the research arena, the pathogenesis, and in the treatment modalities, prevention?
I think it's a terribly frustrating area of COVID because we, as you say, we have a case definition, although there's not complete consensus on that. But I think really frustrating that we don't fully understand the pathophysiology and therefore can really not design a thinking around how to address this important manifestation of the COVID infection. So I'm really glad that you're emphasizing how much research is being now done to hopefully propel our understanding of this important aspect of COVID. And I do take your point. Hopefully everybody will appreciate that vaccination is reducing the risk of COVID. So that's something you can do in advance. And probably you say 1 and 2 doses, and maybe if you could reflect on that, Barbara, 1 or 2 doses, but typically we're now down to dose number 3, and in many places the bivalent vaccine also with dose number 4. One would think that would also further help to reduce that risk. What do you think?
That's a good point. I think these studies are yet to be done, but you're right. That's the data that have been reviewed were from the time when the question was, did you have 1 or 2 doses? Now the question is, did you have 4 or 5? So that kind of data may still evolve. The lack of a case definition makes life very difficult. I have a feeling that case definitions will be coming forward and be agreed upon soon, also for reasons of the economic implications and insurance implications and so forth. And of course, this may lead to people staying out of the workforce for prolonged periods of time. And that's something people may not currently consider when they think about, should I get vaccinated or not? That this may be something they may be able to do something to prevent themselves. The antiviral landscape needs to be studied closer. We may need to see if these 5 days are really sufficient. Do we need to do follow-up testing to make sure we've really taken care of the viral load, or other ways of following up on treatment duration? We know from other antiviral treatment courses and studies that sometimes this varies individually. In flu, we know that children exhibit a much higher virus load, which takes longer to suppress. Also, immunosuppressed patients may require longer treatment courses with anti-flu medication, and this may also be the case with anti-COVID medication. So antivirals are not the same for everybody. It's in some cases you need longer, in some cases you need more support otherwise, in addition to the antiviral. What I find fascinating is the tissue injury. That's something objective to me. Like, that is helpful if you have a patient with long COVID and you have the resources to do, an MRI or to look at the lungs more closely to understand why they're feeling short of breath, for example, and you can explain to somebody, okay, this is really visible. There's some tissue injury still visible in your lungs. Take it slowly and wait until that heals. I think that's probably quite interesting to be able to give a patient something to hold on to, that they're not making this up, that you recognize what they're dealing with.
No, thank you. I guess the other aspect that I'm just wondering about whether we can unfold a little bit. People have, the term long COVID is a qualitative statement. Either you have it or you don't. But of course, we know that if you have it, it can be relatively minor symptoms that don't in an important way influence your quality of life, or they can be absolutely devastating. As I'm thinking about this area, I would really think at some point we should have, it's almost a two-dimensional axis, because there's time and there's intensity. And to plot those who suffer from COVID into that grid, if you see what I mean, because otherwise you also have the potential, as the experience is, that people who experience long COVID, that over time that the symptoms regress, although may not totally disappear. That dynamic change sometimes, at least when I hear people talk about it, it's sometimes lost because either you have it or you don't, yes. If you see what I mean.
Yes, and that's something in general I think that is needed with the Vaccine Safety Initiative. We've been working on mobile apps and similar things to help people assess disease severity in a number of respiratory viral infections based on their individual symptoms and their expression of disease. And you can repeat these assessments over time while you're sick, but this can also be helpful with long COVID or long other respiratory viral infection symptoms to see, okay, so now I'm at a score of 3, I'm lingering there, then I'm down to a 1. That can also help the communication between patient and the healthcare professional. Exactly. Say, okay, you are frustrated because you're still not completely back to baseline, but last time I've seen you, you were 14, now you're 7, so you're on the right track.
Exactly.
It's not an on-off phenomenon. And that transition from being sick to complete recovery just takes some people longer than others. And that doesn't necessarily mean you have a long COVID. It just means you may just still have a dry hacking cough for a while, but otherwise you have recovered. So there is a lot of diversity in how patients cope with COVID as they recover. So I would say, as a take-home message, what we do know is that the evolution of COVID-19 variants will affect the use of monoclonals, as we talked earlier, but not the efficacy of antiviral medicines as they have been studied and recommended for COVID patients. The timing of symptoms and patient-specific factors will influence the selection of your antiviral medicine. Again, look at the guidelines. These are very good slides, I think, that Jens has presented here, that simplify it for you, that you can put up in your practice if you need it. Think about how long has the patient been sick, what are their risk factors, and then you look at your treatment recommendation. Then there's continued work that needs to be done to define long COVID and to understand better how to diagnose it, how to recognize it, and then how to manage and prevent long COVID. But remember, the vaccines are the best we currently have to prevent long COVID.
Thank you very much to Dr. Lundgren and Dr. Rath, and thank you to our listeners for joining in. As a reminder, to view the full Emerging Insights on Outpatient Management of Acute COVID-19 and Long COVID in Europe program on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.